Hello everybody. For this lesson we're going to discuss documentation. I would say documentation is probably one of the most important things that we do not correctly do, and I think that documentation is probably one of the most common reasons why we get in trouble with our jobs at EMS. We're going to discuss why is documentation so important, the types of documentations, what to document, how to document a patient encounter or a call, and some of the recommended minimums that you should document on different types of calls. So why is documentation important? It is a legal record of what has occurred during an EMS call. It takes about 5 to 7 years for an EMS call to go through the court system and to go to trial. It may protect you during trial because it may be just the fact that this EMS documentation is important to some sort of criminal trial, for example, a murder or rape case or something like that. It is not uncommon to see EMS personnel involved in those types of calls. Neither is it not uncommon to see EMS personnel pulled into DWI cases to give a description of what they saw and found whenever they had an interaction with the suspected DWI person at that time. Again, it may protect you in a trial. Most of the time when paramedics and EMTs are being called into trial, it's because there's a perception that they did not do something correctly. And oftentimes that perception is supported by the lack of documentation that has occurred in that patient record. Just remember, this is a super important legal document that once it goes off and is locked out, is going to be there forever. There is in some cases a statute of limitations, but not always. There is also the opportunity, for example, if you take care of a minor and you do something that is not medically acceptable and you cause harm for that patient, they actually have that record can sit dormant until they are 18 if you have not already got into legal trouble for that transport. You could, when that child turns 18, see it. So you could potentially, it may be 10 or 15 years down the road before you see this documentation. It obviously may prevent you from even going to court, because if you documented appropriately of everything that you did and everything was correct, there is now no case for it. The documentation is for your protection. That is the most important thing. What you do and don't do is going to show up in this patient chart. It also supports your billing information, as far as, yes, eventually we're going to get insurance information, we're going to get demographics, and we're going to get every bit of information about that patient so that we can create a bill. And a lot of times that is what is keeping us with jobs. If we cannot bill and our employers cannot get some type of reimbursement back from that transport, or a majority of the transports, at some point they're not going to be able to afford to buy new ambulances, new equipment, or hire new personnel or give us raises. So we really need to make for sure we get that billing information correct. Also, depending on how you bill, especially with Medicare and Medicaid, you can get in a lot of trouble yourself, even if you inadvertently done something wrong with some of the billing. You can still get in trouble there. So make for sure that when you're writing these PCRs, you are in fact writing everything as accurate as possible. Now, I'm not here to tell you how to write a PCR for billing. That is going to be up to your individual department to provide someone from your billing company or your billing agency to come in and have a discussion on how you should document for billing purposes. Other professionals may also look back at your documentation. Just because you have done a chart and when you're done you lock it off and it goes off to Never Never Land, a lot of people think that this chart is gone, you'll never see it again. And that is far from the truth. If you are transporting any kind of patient, used to we were really concerned about traumas and cardiac patients. Now it's trauma, strokes, heart attacks, just general medical patients. Even a patient who is a general medical patient that has now been admitted into the hospital, it's not uncommon for the case managers to go back and look at how you documented that residence to determine whether or not it is safe for that patient to even go back home. That is super, super duper important. Maybe the nurses or the physicians want to go back and look and see how many times you have transported that patient or been to that patient's house because of a non-compliance issue with their medications. Again, that kind of helps them make some determination of how they need to proceed when they're managing this patient. Types of documentation. First one that we're going to talk about is the handwritten drop sheet, and that is exactly what it is. It's going to have just down and dirty information on it. You're not going to get a whole lot of detailed stuff on it because that's not what it's intended to do. This does not circumvent the requirement to have an EPCR. We're looking at times, dates, what was the time of the call, what time do we make patient contact, what time we drop the patient off at the hospital. We're looking for basically a summation of your CAD times, where the call was at. That will be important. As far as was the patient at Walmart, was the patient at some other dollar store somewhere. Maybe they were out in the middle of the street, and when it came about that there was some conflicting information later on about where you found this patient, the nurse or the doctor can go back and pull that drop sheet and find that. Receiving facility. Now this is important because what will happen is, even though you may only have one hospital in your county, not every county in North Carolina has only one hospital. Not every county in North Carolina that has an EMS agency goes to that specific county's hospital. They may go to other adjacent hospitals in other adjacent counties. It is absolutely imperative that you get someone, a nurse or a physician, PA, preferably a nurse, to sign that they have received this patient. There should be a printed name that is legible, and there should be a signature along with the time that you gave the nursing report to the nurse. And yes, you are a paramedic, you're an EMT, you will be giving a nursing report or a handoff report to a nurse. Gross treatment, what are we after there? We are after, did you intubate them? Did you have to start an IV? Did you have to put them on CPAP? What were the CPAP settings? How much fluid did you give them? Did you do a 12 lead? Did you give them any medication, for example, fentanyl, Zofran, any other kind of cardiac medication, anything whatsoever? They're not really after times on the drop sheet. If you have the ability to do that, then that's absolutely fine. I would suggest that you do, especially when you start talking about many of these medications. There may be an opportunity for the hospital to do a follow-up dose after they have been dropped off at the hospital, but if they don't know the dose, it's very difficult for them to proceed with that. So at least try and put some times along with your medications if you can possibly can. Again, this does not take the place of the EPCR. It is strictly just showing that you dropped the patient off. This actually can save your hide in the fact that you are now not abandoning the patient. There's been cases of where EMS have dropped patients off, didn't get a signature, and that EMS crew was accused of abandoning a patient when in fact they did not. The other type of documentation is electronic or EPCR. With this being said, there are so many different types of electronic documentation software out there. You may love yours or you may hate yours. Most of the time it's a love-hate relationship. You just love to hate electronic documentation. Also, electronic documentation is not limited to the software that you're utilizing. It is not uncommon to import your call information from the 911 center, from the 911 center CAD. It is not uncommon to upload the cardiac monitor data as far as blood pressure, heart rate, 12 leads. Those things are time stamped. So on a sidebar with that, you need to make for sure that your heart monitor clock is relatively close to the 911 center's time. That's going to be difficult to get it down to, to the exact minute, the exact second. But what we're talking about here, we're talking about a relative closeness. We don't need them to be 30 minutes off, 2 hours off, that kind of thing. Just a couple minutes, that's really not going to make or break anything, but it does kind of give you a reference point and some kind of a timeline. Now, what is important is when you upload the vital signs and anything else that is electronic form up to your EPCR from your cardiac monitor, whatever it uploads is what it uploads. If you believe that it is showing a pulse oximetry reading of 54% erroneously because the pulse ox probe fell off the patient's finger at that time, or maybe their pulse oximetry was low, not because they were hypoxic, but because they were cold, those things need to be documented in the chart. Don't just go and delete them, because what will happen is if this call goes to court, all of those records from the heart monitor from the 911 center will be compared against your actual chart. That also brings up another point with your 911 center. The times are the times. If you believe the times are incorrect prior to having those times imported into your chart, you need to call the 911 center, allow them to edit them, allow them to put notes into their CAD system to support what happened, then import it. The rationale behind that is that it's on a recorded line. You've had a conversation. There is a documented conversation that has been recorded of you saying, I don't believe these times are right. This is why. This is what was going on. And oftentimes the reason the 911 times are not correct is just because the 911 center may have been busy, or maybe they just didn't hear you because of other radio traffic. But get those times changed through the 911 center before they're imported into your EPCR. Again, that's another check and balance, and that's going to save your hide later on. It serves as a more detailed depiction of the call. What you saw, what you heard, what you smelled, everything that happened, it's going to be in there. It is required. All states in North Carolina, without exception, does require that you submit an EPCR, and it must be completed within 24 hours of the call. That is not something that somebody in an office down the hallway from you come up with. This is something that is in North Carolina law. You have to complete that chart within 24 hours of the call. North Carolina Office of EMS can actually come after you because you didn't complete your chart within 24 hours. Usually they don't, but if it's a habitual thing, they know. Now, this EPCR is used by your QA officer or your training officer. Your medical director may look through it. They may be looking for specific trends along with the QA officer. It is not uncommon for QA officers and medical directors to go through charts and specifically query when there was a callback for medical orders and medical direction. If there is a specific case where people are calling for one specific thing on a regular basis, that may be an opportunity for your EMS director, your medical director, to go in and change something from a call-in order over the telephone or over the radio to a standing order so that you don't have to call so many times. It is obviously used by billing to show that we did the transport, and it also, how much you document can affect the level of reimbursement that you get. Do not, under any circumstances, falsify any of this documentation to get a ALS1 versus an ALS2. You want to make sure you're actually billing appropriately. Attorneys. Now, that's a broad topic. That could be your attorney. That could be the attorney for the EMS agency. That could be the county attorney. That could be the patient's attorney. That could be the hospital's attorney that you took the patient to. It could be any number of attorneys. Many times, all these attorneys have are a list of standards, and in their mind, it is no different than a checkbox. If that checkbox is not checked, in their mind, it was not done, and that was a failure of care on your behalf. So if you don't document well, and you don't document why you didn't do something versus why you did something, that is just ammunition for these attorneys to go after you. Now, what do you document? In one word, it is absolute the simplest thing in the world. Everything. Everything. You're going to document accurate times. Again, if the times are not right, call back to the 911 center, have a discussion with the 911 center as to why you think the times are incorrect. You want an accurate location. Sometimes we will get dispatched to one place, and in fact, that patient is somewhere else. That needs to be documented in your chart that you were given an incorrect location of your patient, and there was a delay in that patient receiving care due to the fact that you couldn't find that location. Or, for example, a hunting accident or some type of accident that's off in the wilderness or in the woods somewhere. It took you 15-20 minutes to get to the patient. Well, you signed on scene, and it took you this exorbitant amount of time to make patient contact. You have to describe. I had to get on a four-wheeler with the fire department to gain access to this patient, and all I had was my jump bag. That will come into play in some cases, because again, standard of care, if you got a patient having chest pain and you don't put them on a heart monitor, it may just be simply that you could physically only carry that jump bag, and your partner had to carry some other equipment to just gain access to the patient. That stuff needs to really, truly be documented. How did you find the patient? Was the patient setting up? Were they talking, walking? Were they laying face down? What condition were they in? Were they in urine and feces? Were they in blood? Were they in a cold room? Were they in a hot area? What were they in? Because that's going to help kind of set the stage of the whole call. And you literally are trying to tell a story. Personally, I'm not the greatest in the world of giving these very exuberant and elaborate scene descriptions, and I know that. So personally, I have to work extra hard on trying to get that information relayed out like it needs to be. Why are you there? You know, that sounds kind of like, well, duh. But really and truly, why are you at that call? Why are you with that patient? Did the patient call? Did the patient's family call? Did a bystander call? And what was the perceived problem of why you got called in the first place? What interactions did you have? Any interaction with a patient needs to be documented. Any interaction with law enforcement as it relates to that patient needs to be documented. Any interaction with family or bystanders as it relates to that patient. It could be that a bystander gave you a description of what happened and what the patient said. That those things don't jive up. You need to put both stories in there. The patient said this, this, and this, and this, and the bystander said this, this, and this, and this. They're two totally separate stories, but you need to document it and show that there was a discrepancy in information, because again, that could come back to haunt you later on. Your assessments. When we actually are talking about assessment, yes, there is usually a section in EOS, in EMS charts, image trends, whatever you're using as far as documentation software. It doesn't matter. You need to document, on my arrival, I found the patient laying in this position in feces and urine, insert what they were laying in here, and how did they respond to their environment. So we're basically doing basically like the pediatric assessment triangle, except for we're doing this for all adults. You know, how were they responding to their environment? What was their color? What was their work of breathing? That's kind of what we're looking for when we do our introductory statement in our patient chart. your treatments with all times. Again, they don't have to be exact. It's more preferential that you get the exact time. But we also know that depending on what piece of equipment you're looking at, you may get a time here that may be 1 minute off from your watch or from your computer. Everybody gets that. So we're not 1 minute isn't going to make or break you generally, just as long as you stay within reason of that. How your patient responds to treatments. I get to look at different charts throughout my career, and the things that I notice that are absolutely amazing to me is I'll see a patient who received a breathing treatment, and there's never any documentation as to why that patient received a second or third albuterol treatment. We'll just simply say patient receiving albuterol. A few minutes later, patient receiving albuterol. And that is not what needs to be put in a chart. Patient was given an initial albuterol treatment. Patient did not respond, continues to have wheezing and difficulty breathing with low O2 sats. That is just something just that simple is all you need. And your logic for the treatment with a protocol listed, we have to practice under medical direction and under protocols. And if we're not operating within protocols, then we have to call and get orders to do it. We cannot run independent of our protocols and medical direction. So when you are going to give Zofran, why are you giving Zofran? Are you giving it just because you want to give it, or is it because the patient is complaining of nausea? Those are important things to document. What protocol are you using? Are you using the nausea and vomiting protocol? Are you giving somebody Ativan for the fact that they're excited and there's something going on that you just need to calm them down? Are you using that under behavior protocol, or are you just randomly giving it? Those are very important things that you need to remember whenever you're going back and documenting. It keeps us honest. I really believe that doing documentation like this really and truly keeps us honest. It really paints a good picture of what we're doing out in the field, and it supports the fact that we are truly professionals and that we truly are doing what we believe to be best for the patient at that time. Now, later on, it may come out that we didn't have all of the information and we were just dealt a bad set of cards. That's okay. But as long as we can document why we did what we did, and I think when you look at the list that I have here, this list is going to be a good set of basic requirements for your documentation. How to document the patient encounter. First and foremost, be accurate with your times. Really try to be as accurate as you possibly can with your times. Again, everybody knows that there's going to be 1 to 2 minutes off depending on where you're pulling your information, but do really truly try to be accurate. Be truthful. Just absolutely be truthful with what you saw, what you did, and what you didn't do. I can promise you this. I can absolutely promise you that if you're not truthful in what you did or didn't do, it will come back to haunt you at some point. Write complete thoughts. That means write entire sentences. Actually be articulate in your writing of this chart. When you are writing the chart, it should flow almost like a novel. Do not use abbreviations. Again, this thing's probably going to go to court in a couple of years, or may possibly go to court in anywhere from 5 to 7 years, or may even be longer than that. You just don't never know. You may be completely out of EMS, and you're going to be expected to read off this chart or remember what you did or didn't do based off of how you wrote it. Well, if you used a whole bunch of abbreviations and you used jargon in there, that is not you should never have jargon or either abbreviations in any of your charting, just for the simple fact, again, you may not remember what it means. We all know there's certain jargon that we use that to the general public it sounds like we're being horrible people when in fact we're not. So again, keep it out of the chart, off of the paper chart and off of the electronic chart. Keep it subjective. This is what I saw. This is what somebody told me. This is what I did. This is what I didn't do, and this is why I did or didn't do these things. Do not, under any circumstances, put your personal feelings in this chart. That totally discounts your credibility in making an unbiased decision for this patient. Do not put personal feelings in charts. I've seen it over the 34 years that I have been doing this, and it really totally kills the credibility of what that paramedic or EMT is trying to do. So don't do it. Here are a couple examples of both good and bad. You can see on the left some examples of what would be considered poor or bad documentation. As you can see, it's filled with very short, simple statements, nondescript. Yes, you understand that there was an EMS call to a patient that had maybe chest pain, maybe not chest pain, because CX can stand for other things other than chest pain. You may, instead of it being CX, it may be CP. We know that based off of this, it was a 56-year-old male complaining of chest pain for 4 hours. ATF, we all know that ATF could be alcohol, tobacco, and firearms. There was no relief from nitroglycerin or aspirin. 12 lead was negative STEMI with normal sinus rhythm. Patient was on O2, IV monitor, nitro, take to the ED. All right, so you kind of get a little bit of an idea there, but let's look at some different examples of those lines kind of spread out and with some more documentation added. EMS was called to a patient complaining of chest pain for about 4 hours without relief from his prescribed nitroglycerin. Patient has also taken 4 baby aspirin at 81 milligrams each for a total of 324. The patient was found sitting in his recliner upon our arrival, continuing to complain of chest pain. Initial assessment showed the patient to be pale, diaphoretic, with signs of respiratory distress. Now, what you're going to have to do is, if you look at these first 2 paragraphs or lines, this kind of really paints a picture of what you found when you walked into the door. You will have to kind of go in a little bit further at some point, and probably the next paragraph would be patient's respiratory distress signs were nasal flaring, tripoding, intercostal retraction. You heard fluid in his lungs, and you will also take that and document a pulse oximetry reading. There needs to be, when you document a 12 lead, you need to write it out. The initial 12 lead EKG did not show any evidence of a STEMI. No ST elevation or depression was displayed. That's very candid. That's just there's no opportunity to misinterpret that. The cardiac monitor displayed a normal sinus rhythm with a rate of 83. So you have also separated this out a little bit, and you've shown that not only have I done a 12 lead, but they're placed on cardiac monitor. And it would behoove you for each one of these things to actually, when you go into the patient record and you're adding in your actions, the 12 lead would be a specific action in the chart. The application of the cardiac monitor would be a specific action. When you put the cardiac monitor on the patient, you should actually put in there the patient was placed on a cardiac monitor displaying a normal sinus rhythm with a rate of 83. The 12 lead was performed, and we did not see any evidence of a STEMI, and there was no ST depression or elevation displayed in any leads. So again, you're giving a very descriptive thing. Paramedics have been sued because they didn't document that a patient did not get adequate care because they weren't displaying signs and symptoms of XYZ. So you want to make sure you document that. That also helps on the back end whenever they get to the heart tower or wherever the PCI facility is. that person, they have a STEMI coordinator in most places in North Carolina that will go back and look and see what your chart says. Per chest pain protocol, again, we are documenting that this patient, we were operating on the chest pain protocol. A 12 20 gauge IV of normal saline was started in the right arm. It was now you got to document that the IV site flushed well. Here's what will happen. We will start an IV out in the field. That IV at some point may blow when they get into the hospital. And the first thing that will happen is if we did not document that the IV flushed well, the patient did not complain of any pain, there was no swelling at the site, no redness, and we need to document that IV site at least 2 more times in our PCR, in our electronic PCR, to show that we went back and reassessed it, especially if you're giving something that is going to be caustic to those veins. If you're hanging a pressor, if you're giving Phenergan, if you're giving anything whatsoever that can cause damage to that blood vessel, to that area, if you have a bad line, you always flush the line before you give the medication if you can, and document that there was no swelling prior to administration of that medication. Again, that's saving your butt. Patient was transported to St. John's Regional Hospital Emergency Department for further evaluation. Now, you could actually take that a step further and go, they were transported to St. John's Regional Hospital Emergency Department for further evaluation. We bypassed our local hospital to transport to this hospital because it has a PCI facility. That is very appropriate documentation. When we arrived at St. John's Hospital, the charge nurse stated there was not a bed available, so we remained with the patient on the EMS stretcher, and we continued to monitor the patient until a bed could become available. When that happens, you need to document times very, very well on that, because that kind of also, that serves a couple of purposes. Again, it covers your butt. You're documenting that you are continuing care. You just didn't let them lay on the stretcher and essentially die. You continue to take care of your patient as you should. That also shows documentation back to EMS leadership. Hey, this is why it took us so long to turn around, because we're supposed to be turning these calls around in about 30 minutes. And if we're not doing that, we have to have some kind of supporting documentation to prove it. We're going to discuss some documentation suggestions for chest pain and STEMIs. This is not an all-inclusive list. None of what I talk about today on this PowerPoint will have an all-inclusive list about anything specific. These are more general ideals and recommendations and encouragement type of things. If you or your department wants a specific list of things that should be included in documentation of STEMI, strokes, trauma, general medical, those kinds of things, I'll be happy to sit down and help you develop those things for you. And I actually would encourage that you do that. You develop a charting template for certain types of patients so that you can have a level of consistency in charting. It will literally help you on so many different levels. And the template should actually reflect not only national standards, state standards, but the protocols that you're using, so that you have everything lined up in a nice, neat package. So when we're looking at chest pain documentation, some of the bare minimums that you need to consider is when did the chest pain start? What caused it, if anything? If the patient describes the chest pain, which you encourage them to do, you document their own words of describing that chest pain and use quotation marks to signify this is the patient's own words. What has the patient done to try and relieve the pain? Have they sat down and rest? Have they taken their own prescribed nitroglycerin? What have they done? What is your doorway assessment? Now, a doorway assessment is a sick or not sick assessment. I get that. However, it is imperative that you put something in your documentation to show that you did a doorway assessment. You arrive to find the patient sitting in a recliner, pale, diaphoretic, with increased work of breathing as indicated by intercostal muscle use. Nasal flaring. Yes, adults can get nasal flaring too. We focus in on that for kids, but it's also there for adults. And a complete assessment before you give any medication and after you give any medication, or any other time that you see or perceive a patient has changed. Time wise, what are we looking for? Every single time that we did something, it needs to be documented. When we arrived out on scene, when did we arrive at bedside? Because there's a big difference there, and that helps kind of cover our butts if we have a large patient who is in a 3-story house with no elevator or no means to get them down safely. We have to document why it took us so long to get there, because we knew that we were going to have to we had to climb 3 sets of stairs, and why it took us 20 minutes or 30 minutes to get the patient to the ambulance, because they were a very large patient. We had to use stairs. They were having chest pains. So it's not like we could make them walk, which you should never make any patient walk down 3 stairs if they called EMS, but that's another topic for a different day. Again, you're documenting this stuff to paint a story of what was going on. Your transport mode. Did you use lights and sirens? Did you not use lights and sirens? The time you called the hospital and gave the STEMI alert. And there is a difference between giving a standard hospital report and calling with a STEMI alert. Just kind of keep that in the back of your mind. You actually technically should probably be documenting 2 hospital encounters on your trip sheet. One when you do the STEMI alert, and then one when you get a few minutes away from the hospital. Did you transmit a 12 lead, and what time did you do it? And a thrombolytic checklist. People often forget to do a thrombolytic checklist on these STEMI patients and chest pain patients. It is so super important. The thrombolytic checklist can be the one that has come from the state office of EMS. If there is a specific thrombolytic checklist that is being utilized by your hospital, by your PCI facility, that is the one that you need to get your hands on, providing that it doesn't violate any standards with OEMS, and I really don't think it's going to. I think the biggest thing that you take out of this is that as long as you can effectively communicate your thrombolytic concerns or lack of concerns to the receiving hospital, and as long as it's documented, you should be fine. When we're looking for suspected stroke patients, again, it's no different than our STEMI patients. When did this thing start? The best last known normal. And if we don't know that, when was the last known normal? That's when the sign started. If we knew that they were normal at 10 p.m. last night and it's now 5 a.m., we would document last known normal was right when they went to bed, because that truthfully is when we know that they were okay. What are the signs and symptoms of strokes? Every stroke presents a little bit different. And as these things progress and get worse, then we need to know how these things progress with EMS. It may have been a mini stroke. The signs and symptoms, what we thought were a stroke, but in fact it was just a TIA or a mini stroke. After we got partially down the road and we had called a stroke alert, these symptoms resolved. A, we need to let the hospital know the symptoms resolved, and B, we need to make sure we document about what time that happened. What medications did they take for this? It's not uncommon for some of these patients who would develop the worst headache of their life to go run to the medicine cabinet, and what will they do? They'll take an NSAID. And if they have an intracranial hemorrhage and they have taken a buttload of aspirin or Tylenol or something like that, that's going to affect the bleeding mechanism in the body, that's actually probably going to make this head bleed even worse. Go back to your doorway assessment. How did you find them? Sick versus not sick, work of breathing, color, mentation. Those are things that we need to document as we walked into that patient's residence or wherever they may be at. Again, document your complete assessment, head-to-toe assessment. This is going to be super important. And part of this assessment is going to be doing some type of stroke screening. Are we doing our standard Cincinnati or LA stroke screening? And when we do that, and once we find that they are positive, are we then going and doing the men's score or the race score, whichever one whichever scoring system you're using, you can't just use the MEND score and the race score and document one or the other. You've got to also use the Cincinnati or LA stroke screen in conjunction with it. Otherwise, it kind of makes you look like you don't know what you're doing. Same thing with times. When do we arrive? When we arrive at bedside. All the times for all interventions, that needs to be documented very well. And the rationale for those interventions. What time did you leave the scene? Again, it may be a very complex scene, very dynamic scene. We're being held to a 10-minute scene time, and if you're exceeding that, then you need to make for sure you document that. Again, the type of transport mode that you're going by, emergency versus non-emergency. Now, why did I put 12 lead in here? This is kind of interesting. We actually should be documenting whether or not we did a 12 lead for these stroke patients, and if it's not in your protocol, that may be something you need to go back and look and talk with your medical director about, or your training officer, because generally that is a industry standard that we are doing 12 leads for potential stroke patients. They can develop STEMIs later on. Same thing with stroke patients. You want to do a thrombolytic checklist. We often forget this, and we will remember in chest pain patients or potential STEMI patients, we often forget that some of these patients can receive lytics. And how are we going to determine that? We're going to do the checklist for them just like we would do any other patient who is in the lytic category or potential lytic recipient category. So if you have that lytic checklist from the hospital, complete it out, sign it, date it, and give it to the nurse. Yes, they'll probably go back and redo it, or they may or may not. It just depends on the nurse, and it depends on the doctor. If you have shown that they can have faith in your assessment, then they're probably going to take it and run with it. But if they don't have faith in your assessment, they're going to look at it and say thank you, and they're going to redo it, which is again a topic for a totally different discussion. Some quick thoughts on trauma documentation. What are you looking for with that? Again, these are kind of the bare minimums I would suggest that you look at. Again, if you want a specific template, let me know. I'll be happy to help you out with that. What time did the accident occur or incident occur? That kind of will help us determine how quickly we need to react, among other things. The description of the event. How many patients are involved? And if there are any fatalities in the event. What type of trauma is this? Is this a car accident, 2-car accident? Is it a 1-car accident off into the ditch? Again, all this is going to be setting us up for a very good description of the dynamics that occurred during the accident and how these dynamics will affect the patient's injuries and kind of dictate how we're going to manage the patient along with the assessment. We're still going to document an initial assessment. We need to document the location of the patient. Are they down in the ravine? How are they positioned in the car? Are they face down? Are they face up? One of my favorite ones is we found this car with a patient in it down a ravine. Okay, well, what will often come out later on is that the patient actually was partially submerged in water. So now we have other issues that would have been much more easily explained out to the physician and to a different EMS crew had that been communicated out and had it been documented, because that's going to dictate kind of how you're going to set yourself up to manage the patient. What hazards are there around this situation? The hazards or lack of hazards in trauma documentation may be the defining fact of why you didn't do something. Well, if you didn't document those hazards and someone just looks at a chart, how are they going to know why you didn't do something? Well, you have to say, hey, I went to a domestic disturbance call with law enforcement, and when we showed up, it was still an active scene. There was still a person on scene with a weapon, and that person had to be contained before we could actually get to our patient. what is our full assessment? So many times we get so vapor locked in on everything going on that we forget to do a really good head to toe assessment. And how did you treat the patient? How did the patient respond to your treatment? Now, I didn't put vital signs in here, and that's just kind of should be in my opinion, a given. With a trauma patient, especially one that we suspect to have a high level of acuity, these patients need to be assessed, and every 5 minutes that assessment needs to be documented in your chart, along with a complete set of vitals: heart rate, blood pressure, respiratory rate, respiratory effort, lung sound, skin color, skin condition, mentation. All of those things need to be documented. Now, I'm going to kind of back up a little bit. One of the things that we really focus in on traumas are the revised trauma score as well as a GCS. Well, the revised trauma score is based off of the GCS with a couple computations involved there. Most of your charting software will do that for you. However, if you have not addressed all treatable causes and you document a GCS, then that could come back to haunt you. If you have a GCS that is low and you have not gone in and documented that the patient's GCS was 8, we assess for adequate breathing, adequate respirations, applied supplemental oxygen, assisted ventilations, whatever the case may be of whatever you may have done. If you didn't document that in the chart, it's going to really be hard to defend yourself. So just keep that in mind when you're doing all of these things. Make for sure, again, you document it, because again, it will come back to haunt you. These are some general minimums for all of your patient encounters. Even though we've kind of talked about certain specific calls or types of patients, all of your documentation, every single bit of your documentation should have a patient complaint. When that issue started, what made it better, what made it worse, what is your initial assessment, what is their work of breathing, what is their general appearance, where did you find them at in the house or in the yard or wherever the case may be, where did you find them, how were they positioned, what kind of medical history do they have. A big part of how we manage patients, if we have a good solid medical history on a patient, about 80 to 90% of how we manage that patient is based off of their current medical history and what their current complaint as well as our assessment findings are. That's a huge percentage, and it all goes back to history and assessment. A lot of it does. So you've got to make for sure that you're getting that history, you're getting a good solid assessment. What allergies they have. Well, sometimes people will argue, well, that really doesn't apply to us. Yes, it does, because if we give something that they're allergic to, we could potentially cause other problems down the road. What current medications are they on right now? And I also will add in here, I will question the patient. Are you compliant with your medicines? Are you taking them as prescribed? And I will document that in the chart, because that sometimes makes a difference in what's going on with the patient. It helps us understand how we need to manage the patient in certain situations. Was there any medication that recently has been stopped for whatever reason? One of the biggest things you may see is someone who is complaining of a headache or difficulty moving in extremity. They may have a history of atrial fibrillation, and they are slated to go to some type of surgery in the next week or so. The doctor took them off of their anticoagulopathy medication, and now they have thrown a clot. Those are important things to know whenever you're doing your assessment. You need to do a complete head-to-toe assessment, regardless if it's a trauma patient, regardless of what kind of patient it is. You should always document a complete assessment, and you should always document it accurately and correctly. Never, ever document something saying you did it, but you in fact did not. It'll come back to haunt you. All of the treatment that you did, along with appropriate timestamps, that will come back into play for that patient and you potentially when you drop this patient off at the receiving hospital. So in summary, just remember, documentation is important. It does paint a picture of the patient situation. It gives a view from your perspective and possibly the patient's perspective of what has happened to them or what has not happened to them. As far as documentation of things that occur on the call, it needs to be relevant to what's going on with the patient, relative to, again, displaying a story and telling a story that is there. Now, I would also kind of caution you in my summary of this, if it does not fall in your professional purview, if you are, be careful about documenting things that should fall into the category of law enforcement or some other profession, because that can come back to haunt you. So just document what is within your level of expertise, and leave those other things to other professionals. Now, the last one is a good and accurate documentation may, not will, but may save you a trip to court. If you have documented accurately and well, that may save your hide. Now, I can also say that it may also sink you if you are a poor clinician and you documented your care, you documented it well, and now there's a really good case against you. But I hope that's not the case for anybody that's listening to this presentation. I hope that everybody that's listening, I hope they're all great clinicians, and I hope that this is never the case. But again, documentation can save your hide on a lot of different levels and maybe possibly keep you out of court. This is all that I have for this presentation. I do hope that you've enjoyed it. It actually went a lot longer than what I had anticipated. I had envisioned this being about a 15-minute talk. It has obviously turned into something much, much longer than that. But again, thank you guys for your time. And if you guys need anything, you know where to find me.